Yeah, I think, dear, thank you so very much for teaching such an important pearls in managing the sublux, and where you emphasize that you want to maintain the compartment as much as you possible. And the reason, and I endorse that and I do that, I do even beyond some of the things which you showed to make sure that I try to preserve the compartments. But the reason I'm doing all this rather difficult looking and time consuming procedure compared to the other appealing procedures of lensectomy and fixing the lenses anywhere else, intrascleral or transscleral or whatever, is because, only one reason if I have to mention, is that I am able to avoid disruption of the anterior vitreous phase, and therefore I can avoid anterior vitrectomy 98% of the time now, having evolved slowly. So if you can avoid a disturbance of vitreous in children particularly, and therefore a vitrectomy, you are doing a great service. That means you have to take more time on the table, that means you have to be patient, you have to learn some of these little tricks which DR showed, but it is worth the life of a patient. So just keep in mind. Thank you, DR. Thank you once again. I do have a research grant support from Alcon, but there is nothing in this presentation of any relevance, and recognize the contribution of my colleague, Viraj. I think we have learned from the experts sitting here on the dais and Dr. Osher, and the strategy revolves, and we must plan this strategy. Whenever you have posterior polar cataract, even in the slightest doubt, err on the side of believing that this is the posterior polar cataract, and avoid rapid buildup of hydraulic pressure into the bag. That means no hydrodissection, subcapsular or corticocleaving hydrodissection, no. Create a mechanical cushion when you're removing the lens material, central nucleus and the paranucleus, and avoid forward bulge of the zonules and the capsule any time of the surgery. If you do a conventional delineation, which is something I've done it for years and I like that, and you can continue doing it, be careful. Sometimes you can end up inadvertently going into capsular plane, subcapsular plane, and you can be in trouble. So we then developed a technique, what we call inside-out technique, which is same delineation but done from the core of the nucleus. So a little trench created, and from the core, it goes outside. So there is no fear of any inadvertent hydraulic pressure building up in this subcapsular plane, and hydro-rupture is practically avoided. So that is not what this video illustrates. A sculpt or a little trench is created, and you can titrate the depth on the wall, superficial, deep, depending upon the thickness of the cushion you want to create in a classical posterior polar cataract. It doesn't work every time like this in a patient who has a dense cataract in front, but that's not common. This is a patient with a pre-existing capsular defect, and we had to adhere to this closed chamber technique here, because the aim here is to prevent the vitreous prolapsing into the chamber. There is already a defect, and this is on the table. So all the strategy will revolve around to make sure that the vitreous doesn't prolapse, and that's what is the key in all the surgeries that we want to do it. So that's using that soft shell technique, Dr. Titial said. And then use the micro-incision forceps. At the moment, the incisions are made, but the small micro-incision forceps allow me to have this chamber very close, and then I create an anticapsular axis, and with this illumination, you can recognize the posterior tear. And now a trench is created with a flow rate, which is about 12 or 14. And then once again, before I retract the instrument, to prevent forward bulge, I injected viscoat. And then I'm doing, there is no nucleus here. This is a patient in his 20s, so there is no formed nucleus. But still I could manage to produce some kind of demarcation, and therefore I am now able to do this with a cushion. Now, this being a very soft, it's not difficult, but notice my bottle height is very high compared to the flow rate. Flow rate is 5 cc per minute. I put it on a cap vac, the flow rate will never go more than 5. So you can imagine there is no attraction to the vitreous, which is exposed, which is looking at me, but appropriate vacuum. So I have a vacuum of 200, but the flow rate is 5. And a very high bottle height. Make sure that, like AC maintainers of late Blumenthal, who did a great job for all of us, works the same thing. So that's what it is. And once again, before I remove this irrigation, I'm injecting viscoat. And here I would urge you to use viscoat like the Fuchs, because methyl cellulose in contact with vitreous is not a good idea. So now I'm enlarging that incision to 2.2, and then this one will have a toric. As toric, by the way, is always, when I have a toric, either the pupil is small or becomes small, or I rupture the anticapsule or posterior capsule. So toric is a deadly combination with the capsule. But because the tear was for a few days, I decided with the stability of this IOL to do that. And this is the second time I've done like this. I've done 4 cases by like now where the tear is in the direction of the toricity, as you can see, 4 of such cases. Not following posterior polar, but the point is that if you can avoid the vitreous disturbance, and this is the crucial part. Anytime you have a complicated open capsule, pediatric or whatever, please inject triamcinolone before you finish it. I've closed the incision, I'm just removing the viscoelastic, but had there been a vitreous strand, I would have gone pars plana and removed that. So make sure, and this is how it looked a month later, this is how it looked 6 months later. The lens is very stable and thing, but it is this which has changed my management. And I would still keep the same strategy as you saw, and Dr. Ramamurthy and Dr. Chitra yesterday in Halls highlighted how valuable this femtosecond cataract lens laser-assisted cataract surgery is for these posterior polar and other cataract. But this is, in a sense, creating cushion after cushion. When one nucleus is removed, there is other cushion protecting it, and so on. So there is always layers and layers of cushion when you're removing the central lens material. And you can decide on the number of the cushions you want to produce, the thickness, and whatever else you want to do that. So that's what is being done with the femto delineation without opening the eye for those who still are not exposed to the femtosecond. What it does, as I said, and Samresh Srivatsa, my colleague, has helped this clay model, which teaches us how this delineation actually achieves that desirable cushion effect when one layer is removed, other one is protecting, until we reach to the very last epinucleus. So I think this is something we need to understand and keep in mind and protect that posterior capsule until end. Now at this stage, it will happen like any other thing. But I just want to show you very briefly how these things work. In a very brief thing, you just remove the anticapsule, and then with whatever machine you have, but as Dr. Titial said, if you have a machine which monitors the IOP and gives a protection to the surge and so on, is desirable, but you can do with most of the machines. I don't think you need to have a great machine, as long as you really understand the value of the 3 principles we just narrated: closed chamber and protecting and avoiding forward bulge. And it's very easy then to get these one after another. And because the final epinucleus is cut like a laser cut, vertical wall, it's very easy to occlude that tip with the IA, and therefore you're able to remove it with a very controlled manner. So then the lens goes in, which is nothing very difficult. Like few of us here, we use automated foot control device, but it doesn't matter actually. And then you need to rotate the toric, and once again, it's always the toric. Posterior polar and toric is such a combination that we need to better accept and learn it. So this is how that looked at the end of the surgery. So the principles, once again, any plaque cataract should be differentiated from the posterior polar. And posterior polar has a circumscribed rings, bull's ring. Dr. Daldit Singh described that many, many years ago, and have the right strategy. Thank you so very much.